On this episode of Education for the Week, we will be discussing pediatric neck masses and how we can use POCUS to aid in our differential. We begin using the linear probe to the area of concern. Neck swelling can be approached by thinking about it in two different categories: solid or cystic lesions. The most common solid lesions are lymph nodes. A normal lymph node is ovoid in shape, hypoechoic to the adjacent tissues, and frequently contains an echogenic fatty hilum that you see here. This hilum is a linear echogenic non-shadowing structure that contains the vessels, and it appears continuous with the fat around the node. When you put color flow on lymph nodes, the center area will light up. When there is concern for a more infectious process, these normal lymph nodes will lose their structure and echogenicity. They can often be necrotizing and can ultimately form an abscess. Let's now switch gears to cystic lesions. I will be talking about two of them. The first one is the thyroglossal duct cyst, which is located on the anterior neck at midline, and then your branchial cyst, which is just lateral to midline. So seen here is a sagittal image of an anterior midline neck mass, where you see here, this is the thyroglossal duct cyst with its relation to the hyoid bone. We know this is the hyoid bone because bones cause shadowing just inferior to that, like we see here. Thyroglossal duct cysts are often small, usually 2 to 4 centimeters in diameter, and here you see they have some posterior acoustic enhancement and are nice and round and thin-walled. When a thyroglossal duct cyst gets infected, these properties of a simple cyst are no longer present. You can see some echogenicity or debris in it. The wall can be thicker, and these are all signs that you should be concerned for an infected thyroglossal duct cyst. If it does not look simple, it is not simple. The next type of cystic neck lesions are branchial cysts, which are remnants of the second branchial cleft. There can be incomplete obliteration of the cleft, leaving behind a cyst, sinus, or fistula. Here you see a transverse image of lateral neck swelling. This is an image of the branchial cyst filled with internal echoes, with a fistula extending posteriorly to the deeper neck structures. When compressing this lesion, you see movement of these echoes. In comparison to the thyroglossal duct cyst, this is more lateral, can be larger, and can present infected after minor trauma or URIs. Treatment for both the branchial cyst and thyroglossal duct cyst is ENT follow-up for definitive treatment. When patients present to the ER and we are concerned for an infection of these cysts, antibiotics can be prescribed and outpatient ENT follow-up is recommended.